and it's a privilege to present work that has been conducted by 18 scientists from 8 countries over roughly a year, documenting the health and economic consequences of endocrine disrupting chemicals in the European Union. Let me, I see that I have mistakenly started at the wrong slide, so I'll move there. Forgive me there. So there's my title slide, correctly placed now. I apologize. I gave you a bit of a preview for a moment. First of all, my children and I have nothing to disclose by way of conflicts of interest. They wish they could be here. But it's the school here in New York, so they're busy. But to move forward, I've presented here, allow me to remind you to think in the frame of Andreas's presentation on the first day. I'm presenting here the European Union definition of endocrine disrupting chemical. I recognize there are 3 definitions with mostly overlapping features, but I present this definition to frame the conversation first and foremost. Suffice it to say that rapidly accumulating evidence, including research presented over the past 4 days, has documented a range of substantial and burdensome health consequences of endocrine disrupting chemical exposure across the lifespan. In 2009 and 2011, a certain series of laws in Europe mandated that chemicals with endocrine disrupting properties and that may also have harmful health and environmental effects would be essentially banned or phased out. Prior to proceeding with that, that implementation of that proposal, the European Commission requested an impact assessment and specifically wanted to understand better the economic implications of the criteria under discussion. Clearly, there are substantial economic consequences of substitution with safer alternatives, and absent estimates of the health and economic consequences of exposure to endocrine disrupting chemicals in Europe, those high costs of alternatives are likely to outweigh the economic benefits of prevention of conditions associated with EDCs. And so our objective in this work was to identify the scope of health and economic consequences that can be reasonably attributed to endocrine disrupting chemicals in Europe. Now I'm going to revisit a slide that Andreas had in his presentation, bringing you back to the landmark lecture of Sir Austin Bradford Hill. Clearly, for endocrine disrupting chemicals in general, there is substantial toxicologic evidence of potential harm with a variety of, and in degree, of epidemiologic evidence to suggest causation. Clearly, exposure must precede outcome for there to be causation. But when Sir Austin Bradford Hill, roughly 50 years ago, described the criteria for causation in his landmark lecture, he emphasized that causation is a matter of degree and not simply categorical 0-1, with the 8 criteria described here contributing to the decision as to how strongly to judge causation. Clearly, consistency, dose response, biological plausibility, and effect size were important. In addition, the ability to ameliorate the effect and document improvement by eradication of an exposure was an important criteria, and coherence with existing knowledge and consideration of alternate explanations or confounding relationships were also documented as important criteria. I'm going to simply revisit some quotations from Sir Austin Bradford Hill's work because the application of the causation criteria that he first elaborated has varied much and in a concerning way approached this notion of dyadic causation, when there is causation and there is not causation. And specifically in the application of that criteria, Sir Austin Bradford Hill emphasized the need to consider context. So if you're forcing someone to change their diet on behalf of their health, you might need more evidence, for example, than eradicating a potentially carcinogenic exposure. So the weight of evidence that is required to act can vary in the context of the particular scope of the decision that's involved and the consequences of that decision for society at large. And most importantly, he emphasized that uncertainty does not prevent us from needing to act in the context of an environmental or other exposure in society of concern. So how do we deal with uncertainty? Well, more recently in the context of climate change, the Intergovernmental Panel on Climate Change has suggested that there are a range of probabilities that can exist based upon strengths of evidence from scientific knowledge. And with these 5 categories described here, these are the categories that members of the Intergovernmental Panel assigned for certain effects of climate change. And you can see the IPCC openly adopted the notion that probability of causation varies between 0 and 1 numerically. So how do we integrate epidemiologic evidence into that context, taking us from climate change to effects on human health of chemicals? Well, more recently, the World Health Organization has organized a series of working groups to develop systematic criteria for evaluation and grading evidence in degree. And this is becoming the internationally adopted approach to consider the existing studies to date. This slide is busy, but it gives you a sense of how evidence might stack up. Clearly, randomized studies are of a higher quality than observational studies or ecological associations. However, there are specific aspects, going back to Bradford Hill, that might drive one to grade up or grade down. That is to say, there are poor randomized studies that are worse than very solid observational studies that have consistency, dose-response relationship, and other associations of import. So it's fair to say that we have to think about the context of the individual studies and aggregate the evidence and see if they cohere. In addition, for evaluating the toxicological evidence, the criteria are more evolving, but most recently, the Danish Environmental Protection Agency, appropriately given that we're here in Copenhagen, have documented criteria to evaluate laboratory evidence in animals, both for endocrine disrupting mechanism as well as toxic effect. And if the toxic effect coexists with the endocrine disrupting mechanism, one, according to the Danish EPA criteria, can grade that more strongly as evidence for endocrine disruption in animals and laboratory tissues, suggesting that that can correlate with effects downstream in humans. So, how do we pull this together? One of the first steps that we did in this project was to try to unite the IPCC criteria and make it cohere with the Danish EPA and GREED working group criteria, and a steering committee of scientists that I was delighted to work with helped us pull that together and come up with the strength of evidence. As you can see here, we'll test the pointer. If I can actually get it to work, beautiful. So weak toxicologic and weak epidemiologic evidence can lead one to a very low probability of causation, and in the absence of toxicologic evidence to support epidemiologic data, however strong, one would still get a medium probability of causation. Similarly speaking, and you can see the emphasis on epidemiologic evidence here, in that if epidemiologic evidence is very low, but toxicologic evidence is very strong, one can only achieve a low probability of causation, however much it's above 0. And you can see as well, at the very extreme, high epidemiologic evidence with strong toxicologic evidence led us to assess a probability of causation that was very high. So how did we apply this criteria in practice? First, we convened a series of expert panels in a meeting that many of the people in this room attended in Paris in 2014. We identified 5 categories of diseases for which the evidence was strongest, and they are presented here. I am discussing today the output of 3 of those expert panels. The 2 other expert panels, the ones on female reproductive conditions and breast cancer, are finalizing their findings, and those reports will be the basis of future publications. And these expert panels were assembled with input from the steering committee members based upon scientific track record. We asked these expert panels to follow the epidemiologic and toxicological criteria that I described earlier, and use the IPCC criteria to develop probabilities of causation for exposure outcome relationships, beginning with the relationships for which the evidence was strongest and working from there. The prioritization throughout was on identifying dose-response relationships from the epidemiologic literature, as well as reference levels below which no effects were estimated. And alternatively, in some cases, there were situations where relative risks rather than increments in disease were available, and so we adapted the Levin equation to estimate attributable fraction in the context of that type of evidence from which to extrapolate disease burden. Whenever possible, we used representative European data. Unfortunately, in contrast to the United States, these data are more thready in general. I note the Democove State Initiative in particular is a strong effort to document the degree of exposure through biomarker data across multiple European countries, as well as the German biomonitoring surveys. But in some cases, we had to go to individual studies with populations. And whenever possible, we tried to use population representative studies rather than individual convenience samples or studies from populations where there was a particular exposure of concern or direct pathway that might exacerbate that exposure above the general population baseline. We were conservative in estimating biomarkers of exposure and extrapolating that to the European population. We divided populations into centiles and used the lowest estimated biomarker level within that range of percentile. To illustrate more clearly, we applied the 10th percentile of a biomarker to the entire population between the estimated 10th to 25th percentile range, and similarly, we used the 25th percentile to estimate exposure between the 25th to 49th percentile range, etc. And then we applied the exposure-response relationship to this biomarker data to estimate disease. And then we used population-based data to estimate the aggregate burden of disease across each of the 27 countries and sum them. This slide presents our overall evaluations. The expert panels, the 3 expert panels on whom I'm reporting today, identified 13 exposure-response relationships. As you can see, for neurodevelopmental dysfunction, the evidence was deemed to be the strongest, with probabilities of causation ranging between 70 and 100% for organophosphate pesticides and brominated flame retardants. In addition, moderate probabilities, as you can see on the right column, were identified for phthalates and DDE as a metabolite, presumably the proxy for DDT exposure, and their relationships to childhood obesity, adult diabetes, adult obesity, and adult diabetes. More modest probability of causation with a wider array of variability, reflecting degrees of expert panel confidence across the group, were identified for bisphenol A and its relationship with childhood obesity. In addition, a variety of male reproductive conditions were also found to have moderate probability, including relationships of phthalates with male infertility, as well as decreases in testosterone-producing increments in adult mortality, presumably through cardiovascular events. The following slides represent our results by category of chemicals. Pesticides contributed the largest component to both burden of disease and costs across Europe. Specifically, organophosphate pesticides were identified to be attributable for 13 million IQ point loss, with roughly consequent 124 billion euro in lost earning potential annually, with an additional cost of 21.4 billion in intellectual disability. Substantial, though modest compared to other exposure-response relationships, were identified with obesity and diabetes, with roughly 850 million euro in associated costs. For phthalates, substantial burden of disease and costs were identified, roughly totaling about 30 billion euro, with 24,000 additional deaths and associated lost economic productivity of 8 billion euro. I should comment there in particular, We used throughout a cost of illness approach following the Institute of Medicine guidelines in 1981 for evaluating the economic costs of environmentally mediated disease. We did not take a willingness to pay approach, and I emphasize that in the context of death because there's a substantial government literature suggesting that willingness to pay models would lead to a larger cost of those deaths. In addition, roughly 4.7 billion of costs were associated with increases in the need for assisted reproductive technology, and roughly 16 billion euro in associated obesity and diabetes among 50 to 64-year-old women were identified. For brominated flame retardants, more modest decrements were identified in IQ across the European population, with an additional roughly $10 billion in lost economic productivity as well as costs of mental retardation associated with those events, and modest, though substantial, contributions to testicular cancer and undescended testis were identified with roughly a total of €1 billion cost. Finally, for autism and ADHD, multiple EDC causation was assessed to have moderate probability with total costs in the range of 1.9 billion euro, and bisphenol A attributable obesity was documented to cost on the order of 1.5 billion, assuming certainty. Again, these are annual costs insofar as exposure continues in the European population at current levels. So I've presented to this point 13 exposure outcome relationships, the probability, and 13 exposure outcome relationships and their associated costs. In practice, 13 probable events that are negative are not all likely to happen at the same time. If you roll the proverbial dice and you get 16 times, that's a rare event, for example, or 13 times. That's a rare event. And similarly speaking, there is a relatively modest probability that all 13 exposure outcome relationships are null. In practice, economists have developed Monte Carlo modeling to account for what might be the more realistic range of probable events and costs across the 13 exposure outcome relationships. And so this slide presents that Monte Carlo analysis. We examined 1,000 simulations that simulated whether the exposure outcome relationship was causal based upon the probability of causation, and then summed the costs across the 13 exposure outcome relationships. So from left to right here, you have 0 to 1 in the cumulative probability, with costs here ranging from 0 to 300 billion euro across the 13 exposure outcome relationships. I'll begin here and note that even in the most extreme scenarios, there was a greater than 99% probability of a non-zero cost of EDC attributable disease. That is, that there's less than a 1% probability that all 13 relationships are not causal. The costs in aggregate, assuming perfect causality for all the 13 exposure outcome relationships, exceeded 270 billion. The more realistic high extremes for the total costs were in the order of 230 to 250 billion euro. Let me explain further that, as you can remember, there were ranges of probability for each of the exposure outcome relationships. The various colors up there denote low bounds for the probability of causation, medium bounds, the midpoint of the range of probability of causation, and higher bounds for the probability of causation. Even across those three probabilities, you can see there's not as much variability in the distribution of the costs over those various scenarios, with a non-zero cost emerging immediately. That is 100% probability of at least of greater than 0 billion costs in the high scenario, but here that less than 1% probability exists. Even the less than 1 probability of no cost exists in the lowest extreme probability inputs to the cost model. Oh, excuse me. So the median of the red scenario is 157 billion euro. So on average, the moderate estimates suggest that 157 billion euro of costs accrue over these 13 exposure outcome relationships. And the next slide presents a distribution of those costs by exposure and outcome for the middle estimate across all of the models. As you can see here again, pesticides contribute the largest component of that $157 billion cost, as do neurodevelopmental impacts. It's important to emphasize at this point that these are extremely conservative estimates for a number of reasons. First, we looked at a subset of EDCs. While I would acknowledge that the actual number remains a subject of some debate, even the most conservative estimates suggest that we only examined less than 5% of EDCs. We also examined a subset of costs that can be attributed to those specific EDCs. And then the costs that we attributed for those diseases were a subset that were peer-reviewed, published. And that excluded some anguish, pain, and associated suffering that it can elicit a social cost for certain chronic conditions. And so this is a subset of a subset of a subset of the actual costs that can be attributed reasonably to endocrine disrupting chemicals in the environment, speaking again to the conservatism of our estimates. So to summarize, we identified 13 chronic conditions with strong scientific evidence for causation by endocrine disrupting chemicals. Based on current knowledge, the probable costs are 157 billion euro, and that's an annual cost insofar as exposures continue in the environment in Europe at those levels. The costs could be as extreme as 269 billion euro, though that is a low probability event, just as it is less than 1% likely that all 13 exposure outcome relationships are not causal under the most extreme assumptions. Clearly, there are conditions that I'm not reporting about today, in addition to the conditions for male reproductive health, obesity, and diabetes, among other outcomes that we did not examine in this work. This was a modest scope project, and I can explain that a bit more later. And again, the economic numbers do not consider all costs associated with the chronic conditions. But most importantly, the major finding of this study is that limiting exposure to the most hazardous EDCs is likely to produce substantial economic benefit. And that's an annual benefit that will accrue insofar as safer alternatives do not have those related health effects. So the implications for the United States are substantial. They suggest that the cost of these diseases may be equally large there. And insofar as data from the Centers for Disease Control and Prevention confirm that exposures to EDCs based upon biomarkers are at or above the same levels as in Europe, the cases attributable for diseases are likely to be equal, if not higher. And again, this speaks to reprising these analyses in the United States context, which is the basis for future work. For example, the cost of brominated flame retardants is likely to be higher in the United States. For example, the 50th percentile in the European population roughly represents the 10th or less in Europe. And in addition, it's important to note that levels that these diseases we quantified in some cases have decreased from from levels that could have been well attributed only a couple years prior. Insofar as levels of DEHP and other phthalates have decreased between 17 and 37%, the costs that we identified are likely to have substantially decreased compared to what we would have estimated in 2005. And these speak to the importance of considering these costs as international environmental health policy proceeds in the strategic approach to international chemicals management, which are especially important given the global use of EDCs, especially in developing countries. So I'd like to close with a provocative thought. Clearly, observational studies are the strongest designs, and they're often the only ones available to assess environmental health effects and effects of EDCs. Randomized experiments are rare, intentional exposures present ethical concerns, and we have history, in the United States at least, with trying to execute such studies with ethical concerns. Fundamentally, though, I go back to Bradford Hill's initial comments. And I would push this audience to consider strongly that the data that have been published about the global burden of disease to date, which only represents a small subset of the aggregate costs and none of the costs that I've described here that can be attributed to environmental factors. One example that I commonly give in lectures that I give undergraduates in environmental health is that air pollution is increasingly linked to adverse birth outcomes, yet that's not included in the analysis, whereas respiratory conditions indeed are. And that reason for that decision is that the epidemiologic evidence was not judged to be sufficiently causal for that context. Some would counter with the precautionary principle, suggesting that all of these costs need to be immediately incorporated into the GBD. I'm not arguing against the precautionary principle, but I'm arguing here in general in the European context with regard to decision-making about EDCs for a different paradigm, which is neither the precautionary principle nor the current posture for waiting for certainty. Clearly, we need to put probability on the table as a component of a transparent dialogue, making explicit the uncertainties and having policymakers weigh the trade-off of continuing use of existing chemicals against the cost of safer alternatives. A new way forward might involve the following hypothetical. If a chemical has a 50% chance of causing 10,000 cases of a chronic condition at a cost of $5 billion per year, should we spend $2 billion per year replacing it? If you simply multiply 50% by $5 billion, then the economic benefit of preventing that chronic condition is roughly $2.5 billion. So you would spend $2 billion and net save $500 million. So that would be a straightforward decision. Even if the numbers were switched around and it would not be cost appropriate from a pure mathematical perspective, as a society, we're risk averse in general. And we have health insurance in many countries for that very reason. And so even in some cases, I might argue that there might be a net cost from a comparison of the societal cost of ongoing exposure versus the cost of safer alternatives. And there might be situations in that context where we might actually proceed with regulating a chemical on the basis of risk aversion, even when the economics, as presently constructed, do not support it. So with that provoking thought, I'll thank the many people who invested countless conference calls and time and effort in writing articles at no economic benefit to them, as well as the foundation funders who supported what I think is landmark work, as well as to a variety of technical supports, including someone I've neglected in this slide, Catherine Genslavin at EEA, who hosted the second day of one of our meetings, and look forward to your thoughts and questions. As you can see, this was also a terrific opportunity for collegiality and collaboration. Thank you.
Thank you, Leo. Lots of food for thought.